afternoon, everyone, and welcome to our CDPH and CMA virtual grand rounds. I'm Dr. Kim Newell-Green, and I'll be your moderator for today's session, The Continued Evolution of Public Health, Recent Federal and State Changes. As a reminder, the goal of this series is to highlight pressing public health concerns across California and provide timely education to support our healthcare community. As always, we're incredibly grateful to these speakers, those with us today, Dr. Erica Pan, our Director and State Public Health Officer at the California Department of Public Health, especially as she continues to make time for these important conversations to share updates on infectious diseases in California and other CDPH priorities. Today, we're also excited to hear from Dr. Susan Kohler-Menarez, with us now in California after a sojourn as the leader of the Centers for Disease Control, who will share with us some exciting work she's doing in our state. And we'll also hear from our frequent contributor, Dr. Rita Wen, who will give us a lens on other important and timely public health issues. Next slide, please. You can download today's slides and follow along. These are the instructions here. In the next slide, we're going to show you our speakers' disclosures. And I also want to remind you that this series is accredited for CME credit. After the webinar, you'll receive a survey where you can attest to your attendance. And once completed, your certificate will be emailed to you. As we've met Dr. Pan and Dr. Wen many times in these series, I'm going to ask you to visit the internet to learn more about their impressive bios so that we can get the most time with our speakers today. Dr. Kohler-Menarez is not here yet, but should join us soon, and I'm going to introduce her as our special guest today. Dr. Menarez is a microbiologist, she's a PhD, and she's been a transformational health innovation leader with over 20 years of experience driving complex strategy across government, industry, and global health systems. She's overseen multi-billion-dollar biomedical and technology portfolios, launched high-impact public-private partnerships, and shaped national and global policy to strengthen health security and accelerate science-to-market breakthroughs. She was the Senate-confirmed director of the CDC and the former deputy director of ARPA-H, where she led major institutional shifts during moments of national crisis, designed and deployed AI-enabled infrastructure for health, and directed over $2 billion in cutting-edge program investments. She served at the White House, led federal biodefense and health technology strategy, and advised on international security, biotechnology, and pandemic response. As a bridge between disciplines and sectors using science, technology, and policy to deliver real-world impact, we're very excited to have her working in California and soon here with us today. But first, we'll start with Dr. Pan. Welcome, Erica.
Great, thank you so much, Kim. So yeah, I will go ahead and launch in so that we have enough time at the end for questions. We have a lot to cover as always, so let's go ahead to our next slide. And Happy New Year to everyone. See. Yeah, this is just kind of, again, intro to all of us that are presenting to you today. Next slide. So I'm going to talk a little bit about, of course, a very evolving topic in our country right now around immunization updates, a little bit about what's happening with winter respiratory viruses right now in California, just a quick reminder about TB screening in California, and then very exciting progress in our new initiative with the Phoenix that has brought us Dr. Menarez. So that'll be a good one. So the next, oh, and actually I'll let Susan say hello real quick and then we'll turn it back to her after I go through some of those other things.
Hi.
Dr. Menarez, we already introduced you, so welcome.
Thank you.
Great. Okay, let's go to the next slide. Let's go to the next one. Great. So I want to essentially remind everyone that when we passed AB 144 in September of last year, essentially what we were able to do is say that the state of California would continue to follow California Department of Public Health immunization recommendations, and that in general we will be aligning with AAP immunization schedules for children and the American Academy of Family Practice for adults. That bill also allowed us to remain, have insurance coverage that all plans regulated in California are required to cover immunizations recommended by California Department of Public Health. We also added some updates there around liability protection for providing immunizations recommended by our state health department, and that pharmacists may continue to administer immunizations recommended by California Department of Public Health to patients 3 years and older, which has always been sort of the scope of practice there, without a prescription from a physician. So with that law, we were able to remove reference from the Advisory Committee on Immunization Practices when we recognized that there was a lot of that there was a dismantling of the prior processes and prior committee related to that. Next slide. And and also just continue to reiterate that both CDPH and the West Coast Health Alliance continue to recommend immunization of children and adolescents, again, with the AAP immunization schedule. So on our website and in the supplemental slides, you'll see a reference to the great tables that AAP continues to have. And again, a reminder, I've said it on prior grand rounds here as well, but that the AAP has actually been doing immunization recommendations before the Advisory Committee on Immunization Practices was created. There are, of course, historically a lot of great work group activity that had happened with the Advisory Committee on Immunization Practices, but currently we again are continuing to reiterate, despite what's happened with the HHS recommendations, the AAP schedule. Next slide. So one of the recent changes that happened with the Advisory Committee at the end of last year was removing the universal recommendation for infant and newborn hepatitis B infection. So a couple just highlights that I have been finding helpful that have actually been in social media. American Academy of Pediatrics and others have been putting up a lot of nice graphics and facts to help you talk to your patients and families about these changes and why they continue to be important, and why we in California and you all as frontline clinicians continue the recommendations that you have had. So just a reminder on some just key facts. Newborns infected with hepatitis B have a 90% chance of developing chronic hepatitis B. This is different than if you get exposed later in life. So because of the different immune system in infants and newborns, again, they have a 90% chance of chronic Hep B. And of those who develop chronic Hep B, 1 in 4 will die from the disease. So that's why it's really important to vaccinate infants when they are during that time, and to prevent perinatal transmission. And then, of course, some of the things that I think people forget or don't remember is that the majority of people with hepatitis B actually globally don't always know that they're infected. So while the biggest thing we're trying to prevent is perinatal transmission, there can be situations in households or even childcares where it's not just, I think there's been a little bit of a narrative out there that this is only transmitted outside of perinatal transmission from injection drug use or sexual activity, but there have been a large proportion of people who've been infected with hepatitis B where it wasn't actually known what the source was. So it can be a very tiny dose that can cause infection. It could be transmitted through shared razors, shared toothbrushes, definitely through bites that can occur. So again, that is why we've continued to have a universal recommendation for infant and newborn hepatitis B. So I would refer you to a lot of, again, fact check resources from AAP. Your local epidemiologist, which I'll talk a little bit about later, has been a great resource for really translating some of the facts and information into useful sort of bits of information to share with your patients and families, and also some visuals. And these two lower visuals here are ones that I think were a joint creation with the Yale School of Public Health and YLE. And there's a lot of other great resources out there as well that are helpful to as you communicate to your families. Next slide. So what happened more recently too on January 5th? There was a memo from the president that was then endorsed to create a review of the vaccine schedule in the United States. And then the HHS secretary endorsed that memo as well. And in the December meeting of the ACIP, one of the FDA ex officio members also commented on Denmark having the lowest number of recommended vaccines, as far as only recommending 10 vaccines for children versus 17 in the United States. So some of the other new ACIP members prepared a paper comparing the US schedule with 20 peer nations. It did not include any new science, nor did it examine any different disease epidemiology or healthcare systems in these peer nations. Based on that review that they put forward, the Hoag and Koldorf recommended this Danish schedule along with the varicella vaccine. And they put forward in this paper that the US was an outlier with 17 vaccines, although the average number of vaccines amongst peer nations was actually 14. And Denmark is actually the lowest amongst sort of what people would consider peer nations in developed countries as far as the number of vaccines that they recommend. So then they did a sort of evidence paper with that, outlining that, and then the decision memo was submitted to the acting CDC director to adopt a new schedule. And the new schedule essentially has the changes that are indicated in the column on the right here. So they have moved these 7 vaccines to what they're calling shared clinical decision making. So hepatitis A, hepatitis B, flu, meningococcal ACWY, rotavirus, RSV, and for RSV and HPV, RSV actually isn't really a change. There's a change in all of this in the way they're communicating it, but we've always recommended RSV specifically for high-risk groups, and it's actually aligned with the prior recommendations in that infants whose pregnant parent doesn't get a RSV vaccine should get RSV antibody and immunization. So they're calling it a high-risk group, but it's actually what the recommendation was before as well. And then for HPV, we're in an interesting space right now where there is a lot of review on the efficacy of 2 doses versus 1 dose, and I think there has been active consideration and some evolving evidence that maybe 1 dose is equivalent to 2 doses. So more to come on that. I know the AAP and others are looking at that as well. But essentially, the new changes for HHS are calling, instead of routine vaccines, that these 7 should be shared clinical decision making. The important piece around this too is that both for the federally funded vaccines for children and federal insurance, they are still required to be covered if parents do indeed still agree to have to consent to these vaccines. And just want to reiterate with all of you, the West Coast Health Alliance and the California and the AAP all continue to recommend these as part of routine vaccines. Next slide. So I think the other thing that's been evolving here is calling something shared clinical decision making, when all of you as frontline clinicians do that every single day with your patients. I think continuing to do counseling, including benefits and risks of vaccines, charting, including documenting your discussions and decisions with your patients, and continuing to provide informed consent and vaccine information statements. There are certain settings when the vaccine information statements are required by federal law, but of course, just fundamental to how all of us as clinicians practice with our patients is having informed consent and talking about those benefits and risks. So, I think some of the perspective on this is it's causing a lot of confusion. I think just a few bottom lines again are that we continue to recommend in California the routine vaccine schedule that we always have that aligns with the AAP. All of those vaccines are still covered by insurance and thankfully by the Vaccines for Children program as well. And I think there's going to be a lot of ongoing confusion. So again, I would continue to look at a lot of resources that the AAP, healthychildren.org, and a lot of other organizations are doing some great pieces on fact checking and other information as resources for you as you're talking to your patients. I know you are getting more and more questions and there's a lot of confusion, but again, in California and with our West Coast Health Alliance, we continue to maintain the same recommendations because there is not new evidence or new recommendations that are looking at any different risks. The safety and effectiveness of these vaccines are the same and the benefits are still huge. Next slide. Next slide. I'm going to shift to respiratory virus updates too and just tell you a little bit about what's happening here. I think, go ahead to the next slide. So we did just send last week a health advisory out to clinicians just with a flu update. Let's see, back up one. As you all are probably seeing and experiencing, and even anecdotally with having people out sick as well, we are seeing increasing flu cases and admissions in California. It is not too late to recommend and administer flu vaccine for the season to anyone 6 months of age and older. It's also really important, and part of our advisory was to just remind people to, if you have symptomatic patients, especially if they could benefit from treatment, to test them as quickly as possible and to initiate treatment without delay, and ideally at point of care if you can. So that health advisory went out last week. Next slide. And just to give you a little bit of sort of the trends that are happening here, you can see here the trends in flu test positivity in the upper graph there. There has been a little bit of a dip, so maybe we've seen the peak. Sometimes there's a little bit of a dip during the holiday season when there's just less people testing and accessing care, especially for more minor illnesses. You've also likely been hearing about subclade K, which is the majority of what we're seeing as far as flu A circulating in the country and here in California too. Of the flu A strains that have been subtyped nationally, over 90% have actually been H3N2 subclade K, and then over 80% here in California are also the same K. So it's not the exact subclade that was in the flu vaccine composition, and there's still some cross-reactivity. Uh-oh, let's see. I just lost signal. Can you all? Okay, great. We have had 2 pediatric flu fatalities in California to date this season. And then you can also see here in these slides that the RSV test positivity and hospitalizations are increasing, but actually you can see here compared to the prior 2 seasons, it's a little bit lower than the last 2 seasons and a little bit later than one season, and about the same time as the peak that we saw in a prior year. Our COVID-19 activity remains very low. And then the other great resource here is just to look at our retrovirus dashboard, which we continue to update weekly, and you can see what's happening in the state specifically on our dashboard. Next slide. And then our forecasts are showing potential increases statewide, and you can see sort of the regional breakdown as well. And this is sort of what our modeling and projections team has put together. You can see also the first peak on the left here is last year. And so currently the projections, even though there's been a lot of concerns about this subclade K and a potential mismatch as it wasn't the one included in the vaccine, and whether or not we'd have increased severity, which we often see when we have flu H3N2 versus an H1 strain. But so far, the current projections are that we'll still have a lower burden of flu compared to last year. This, of course, could change as we watch over the coming weeks, but that's what the current projections are showing. Next slide. And then this was in that health advisory that went out last week. And essentially kind of just walking you through, just key things to emphasize. I'm not going to walk through sort of every piece of this, but that if you have a patient who has symptoms, it's worthwhile to treat them early, especially if they do meet criteria for severe disease, if they're elderly, if they're young, especially under 2 years of age, and any other immunosuppression, any lung disease. Those are all things you'd want to test early and treat early, because you can definitely see better outcomes if you treat within the first 24 to 48 hours, as much as 3 days of decreased symptoms if you treat early. And of course, anyone who's hospitalized, we definitely recommend treating them empirically while you wait for test results. You can certainly stop treatment. And then there is a new drug, the baloxavir, that is a 1 dose versus 5 days of treatment. There are certain indications there. It's not recommended and sort of tested in kids less than 5, pregnant persons, breastfeeding or immunocompromised, but others may be eligible for that baloxavir. If they're hospitalized, we still recommend oseltamivir just because we have more data and evidence to support the improvement in outcomes there. And then just a reminder that we can see a few side effects in the first couple of days of Tamiflu or oseltamivir. Next slide. And then a quick reminder related to tuberculosis. Next slide. In 2025, so actually this is a year anniversary of when AB 2132 came into effect, that primary care providers do need to offer adult patients TB screening if risk factors are identified. So foreign-born, people experiencing homelessness, incarceration, a contact TB, all of those are reasons you would want to offer a TB screening test, and then if positive, provide treatment or referral to follow-up. So wanted to remind people about that. Next slide. And then I'm really excited to talk a little bit more about our new initiative, Public Health Network Innovation Exchange, or PHENIX. Next slide. And we've talked on previous grand rounds about this. So we are now part of a National Governors Public Health Alliance, which includes 15 states, and a lot of what we're working to think about as far as global health and concerns about the withdrawal of the United States from the World Health Organization. We've joined the Global Outbreak Alert Response Network, which is part of the World Health Organization, and working closely with other public health partners, including this Governor's Public Health Alliance, about how to maintain global situational awareness and continue to partner with other global partners. You already know, been hearing about our West Coast Health Alliance, and you've seen now updated recommendations and joint statements around vaccines. And then here in California, in addition to our Public Health for All Californians Together coalition and the updated laws I just highlighted, we have launched PHENIX in mid-December last year. Next slide. So PHENIX stands for the Public Health Network Innovation Exchange. And really, we've been thinking about this as three different pillars. We're focusing on innovation, and this is where we really want to work to develop advanced technology and funding frameworks to secure a sustainable future for public health preparedness and response. And then as far as collaboration, we're going to continue to build upon our collaboration and leadership in evolving regional and global partnerships. So all the things I just highlighted in the prior slide with a lot of alliances and other partners. And then communications, which is working with your local epidemiologist. And we're a launch partner with YLE and Dr. Caitlin Gedolina for Project Stethoscope, which is looking at social media and engaging with communities to hear better, listening to our communities and getting a better feedback loop on what are they hearing. And certainly right now, a lot of what the confusion is around vaccines and wanting to hear what are the biggest questions people have, how are the messages we are putting out landing, what are the questions they still want answered to help empower them to make healthy choices. So that is part of the communication pillar. And sort of just kind of continue to go in the circle. So Dr. Susan Menares is really helping us lead the innovation part. Dr. Deb Howry, who is the CDC Chief Medical Officer, has really been helping us lead and work with and liaise with a lot of these different partners around collaboration and helping us think about this evolving public health network and system, and how do we continue to make sure we're working strong across the nation to continue to uphold evidence and science and collaborate over time. So those are kind of some quick highlights on that, and then I will turn it over to Dr. Menares to talk more about our vision for innovation and PHENIX innovation. Next slide. Oh, actually, before Dr. Menares speaks, I just want to speak, and then she can jump right in. But I just love this screenshot that Caitlin Gedolina took. That was right before our press conference where we were announcing the PHENIX as an initiative. And a couple of key things here. One are that the governor was commenting on, what an amazing team of women this was, that we were all women leaders, and I certainly just am so honored to get to work with all of these women and have been calling this our dream team. And we were just, so excited right before we were about to open up to present and talk to the press. And the governor was also saying, like, I've never seen Dr. Pond smile this much. No one's more excited than her. And it just was a really joyous moment that I just love sharing. So with that, I'm really, really excited to turn it over to Dr. Menares to talk more about innovation.
Great. Thank you, Dr. Pond. And Ian, thank you for the opportunity to share a little bit more about what we're doing on the innovation side. So some of the context I think Erica has already provided is we're moving through some unprecedented times, both on the push side and the pull side of public health and the technology sector. The changes in the uncertainty in the federal funding landscape, I think are really stressing how will the states be able to continue to enable robust public health preparedness response, whether it's in a localized outbreak or something that is more emergent, or any of the other public health threats that CDPH and really other states face on a day-to-day basis. On the flip side, we're also seeing this incredible evolution in technological innovation and the ability to identify a problem and identify a commensurate potential technological solution that can be brought to bear and deployed and operationalized to mitigate those challenges. And so what the Phoenix Innovation Initiative is really trying to do is to offset the dynamics we're seeing in the federal funding landscape, and to be able to harness the technology. And California is the perfect test bed to be able to do this, where you have extraordinary competencies and capabilities in technology development, AI, big tech, biotech, all of the elements that are necessary to be able to have a robust public health capability. And so the innovation work is what we're focusing on the Innovation Initiative is an independent, non-governmental technology development and deployment engine. So it is unique. It is not another California state agency. It will act independently. Directly funded by non-government sources, so philanthropic or for-profit investors that want to place their resources into an area that they know is going to have benefit to the California public. And then as we develop these technologies that are meeting the needs for public health being in California, being able to scale them nationally and potentially globally to meet the global needs that are also evolving. The technologies that we seek to be able to invest in within the initiative will be validated with real world performance through state-enabled test beds. So making sure that as we're developing these, that we're not just putting in initial capital and then letting the developers have to navigate that process. We're accelerating the development of those processes by enabling these test beds. Seeking a revenue generating model by deploying these solutions into the California state public health labs, or in other areas for CDPH, and then seeing whether or not we can validate that they are actually having the impacts that we had anticipated during their development, and then scaling them through secondary contracts or service fees or licensing or other places to generate revenue to help that Phoenix Initiative continue to move forward, and making sure that the work that we're doing is accountable to those investors, accountable to California State and CDPH and what they need to be able to execute on their mission, and is in support of the patients and payers and providers and other entities that are reliant upon these types of tools and technologies and capabilities to be able to meet those needs, improve health outcomes, and reduce healthcare costs. So a couple other things about this is, as I said, it's not a new California state agency. It is not a procurement authority. It's not a research grant program. It's not a venture capital fund, and it's not a policy type think tank. It is an independent entity that is laser focused on being able to foster these technological solutions and get them into the public health domain. We're still working through what the oversight will look like, what governance will look like. The way we're thinking about it right now is having a blended capital model with oversight coming from the philanthropic side, certainly the California state side, academia and the private sector, all of those entities that are starting to work together because there is this unified recognition of the need and being able to improve these technological capabilities in the public health domain. We're really excited about the support that we've received so far. There's been an outpouring of sort of enthusiasm that this is meeting a need that is not yet been addressed through other various sources. And it's just been really great to see Erica and the CDPH team embracing this idea that they're in a very challenged situation right now, as are so many states, but not slowing down, saying, how can we continue to innovate? How can we continue to be able to meet our mission, and embracing technology across the sort of the entirety of the public health portfolio to be able to address these needs. So I'm going to stop there, but you're certainly going to hear much more about this as it continues to mature and to evolve. And I'm really looking forward to continuing to work with Erica and the team on that.
I was talking without a microphone. Thank you so much, Dr. Menares, for that brief and quick introduction to this exciting and complex, I'm sure, to think about, to conceive of, and to run well program. We're really excited to get the introduction here, and we'll be very happy to follow it over time. So I would love to pass this on to Dr. Wen, and then we'll have many conversations and questions for you too.
Thanks, Kim. And I'll just bring us home with topics in the non-communicable disease space for public health. And you can go ahead and advance the slide. I know there's lots to discuss amongst the wide variety of topics that we've brought up today. So I wanted to start off with the rollout of the 2025-2030 dietary guidelines for Americans called the DGAs. So folks probably saw that in the papers. You might have been hearing about it. So this was every 5 years, the federal government through USDA in coordination with Health and Human Services puts out the dietary guidelines. Most folks would have recognized this around like MyPlate. So MyPlate was we started off with the dietary pyramid. It evolved to MyPlate for the last 16 years. And now this concept of this inverted pyramid has been introduced. And these are the guidelines that were put forward by the feds. Just going to give folks an overview of it. Of course, the details will be in slides that you will have as well. But in the interest of time, I might go a little bit fast just so we can spend more time with Q&A and discussion. So one thing worth noting about these guidelines that came out last week is that they were developed outside the usual transparent evidence-based process that depended on the DGA Advisory Committee recommendations. So that advisory committee had actually put forward a comprehensive scientific review at the end of 2024, and that took about 2 years to put together. It seems like that advisory committee and those recommendations weren't really a close part of the development of these guidelines, and so it's just worth recognizing the context in which these were developed. And so what we are seeing here is a fairly simplified version of dietary guidance that sometimes gives conflicting advice that might be harder for individuals, programs, and you all as clinicians to even be able to translate and then answer questions about what does contribute to a healthy diet to manage and prevent chronic disease. From a state programmatic area, it's also, you can advance, just push forward. There's also a layer of implementation that has to happen across various state and federal nutrition programs like WIC or school meals. And so that typically takes years. It's like a regulatory process. And so that's something that we're keeping an eye on. And you can go ahead and advance. So just highlighting a few areas where there is alignment is that generally there is this recognition of nutrient-dense foods like fruits, vegetables, whole grains. So that is all consistent and in agreement with what we in public health would support. It does support limiting highly processed food, which is great. It's pretty clear about the dangers of added sugar. So this is all good and consistent with proprietary dietary guidance and with evidence. It also maintains the recommended limit to saturated fat within 10% of calories. It promotes water and unsweetened beverages. It maintains the existing sodium recommendations by age group. And it does highlight the importance of fiber and microbiome gut health, which is in alignment generally with scientific consensus. Next slide. Areas where I think it's going to take us and others a little bit of time to really think about whether or not there's truly an alignment with evidence-based or there's sort of confusion introduced. Just a few examples. So the visual model, as I'd mentioned earlier, MyPlate, it's fairly widely recognized. There is more clear communication about relative portions of how much of your diet should consist of fresh produce, for example, relative to protein and grains, whereas the inverted food pyramid can cause confusion about what is the actual priority, how much should folks be eating of what various things. There's also maybe a misperception that whole grains, which is at the bottom of that base, should be somehow deprioritized. So it doesn't really address portion size in ways that might be easily understandable to your patients or you as you're trying to explain how to eat healthy. There is this increased emphasis on protein that on first glance doesn't seem to be evidence-based that we would move that up to 1.2 to 1.6 grams per kg per day. There seems to then be this risk of an over-reliance on animal proteins for animal products for protein consumption. Folks were generally glad to see that regarding saturated fats that the less than 10% guidance remained, but it then does seem to conflict with other messages now in the guidance that seems to encourage use of buttered beef tallow and full-fat dairy, which is higher in saturated fat. So that conflict is likely to cause confusion amongst your patients of what are they supposed to do about saturated fat to even remain within 10%. Go ahead, Advance. This is one that I think has been embedded in our medical training about alcohol intake. That's sort of the goal, like the cutoffs for women, less than 1 for women, less than 2 for men. But now the new guidance just sort of says to reduce intake, which is, again, like vague and probably confusing to folks. For vegetarian and vegan diets, the previous guidance focused on, with some purposeful planning around things like B12 and other vitamins, that this could be an adequate and good diet for across the age ranges, whereas in this current DGAs, the framing appears more cautious and emphasizes what could be lacking and sort of the challenges with it, rather than focusing on the potential benefits of having a primarily or entirely vegetarian or vegan diet. And then similarly for fiber, whereas there used to be clear intake recommendations, now it does still mention fiber as a priority, but there isn't actionable intake guidance, which again might be confusing to counsel folks on. And again, the pyramid itself seems to de-emphasize fiber-rich foods based on where it's placed in the pyramid. Go ahead and advance. The last piece that has more, oh wait, a couple more. So added sugars. So again, great that added sugars was deprioritized. In terms of, it then specifies less than 10 grams per meal, which on our first analysis, there isn't real great evidence to suggest that per meal matters versus daily intake of sugar. Practically speaking, it might be hard for folks to abide by that, and for school meals and other food programs to abide by that. Artificial sweeteners, whereas the prior guidance used to say what were safety, like what sweeteners had been studied in terms of safety within established limits. This version is more cautious about the use of artificial sweeteners, and then there isn't really much clarity about the different sweeteners and their safety profiles. The last piece has more to do with like state and local and federal nutrition programs trying to figure out how to then adjust the food programmings and food offerings to then align with these new guidance, which will normally takes a few years anyway around regulation. So more to come there. Switching gears, you can advance the slide. Folks may have also been hearing about, unfortunately, this outbreak of Amanita poisonings across the state. And so typically in any given year, we'll get 3 to 5 cases to poison control. And in about a 2-month period, we now have 35 cases, including 3 deaths and 3 liver transplants. 1 young child was affected. We had put out press releases and a KHAN last month around this. There seem to be initial clusters around the Monterey area and the San Francisco Bay Area, but there is statewide risk because these mushrooms grow in a variety of different areas across the state, especially next to oaks, pines, and hardwoods. You can go ahead and advance. We had hoped that this was an outbreak that was wrapping up, but it hasn't been. And so here's just some characteristics of who's been affected to think about the patients that you might want to message more to. So we have seen a variety of languages spoken by those who have been hospitalized for Amanita poisoning. Unfortunately, our data systems are quite limited in terms of giving further demographics. And so we're even having to just guess at some of these demographic details. So just sharing that at least we do know nearly 90% of cases had Spanish appearing surnames, which I know is not like a great way to describe any group, but that was the closest we could get to better understand which communities needed more messaging. We are seeing that of the cases that have been interviewed that we have information about, there seems to be sort of a familiarity with mushrooms based on their home country, and then mistaking those mushrooms for like what is grown in California. And part of cultures where foraging for mushrooms is like a more common cultural practice. We're not entirely sure why there's such, we do know that this has been a really robust mushroom blooming for the state. I mean, that is primarily what's driving the outbreak. It is related to the heavier rains, but folks are saying like this is just a very robust blooming environment. And so just a lot of mushrooms out there with this toxin in it. We're also getting deaths from dogs and animals that are off leash and then unfortunately consuming these as well. Next slide, please. Oh, and sorry, just one quick thing about the counties. That's where the cases are hospitalized. We still don't even, it's a little bit difficult getting the county of residence of folks. So often folks are traveling into other cities and other counties to forage in parks and areas where they're allowed to or where there's more access. And so these are just the hospitals where folks ended up getting hospitalized. Next slide. And so again, trying to relay that we were hoping that this outbreak was petering out, but every time there's a heavy rainfall, there's more robust blooming. So just know that it has continued so much so that we're actually putting out another KHAN probably by the end of this week. You'll see an update that those initial counts in December have increased. And so just wanted to share that the risk is ongoing. So please do communicate with your patients, particularly about foraging behavior and outings. Next slide. And so just some resources here, educational resources in a variety of languages. We know that at least in some cases, Mixtecan populations were affected, for which there's a challenge in written communication. And so we have some videos in Mixteco there posted. Next slide. Okay, really quickly, just wanted to share that we just launched our cannabis poison control dashboard. And so we have a lot of information about cannabis surveillance, especially since the legalization of cannabis in 2016. Just wanted to highlight that we now have visibility on the rise in poison control calls in that time for both unintentional and intentional ingestion and poisoning. You'll see that it's near a threefold increase. That's the figure on the left, looking at the blue line since 2016. You can go ahead and advance. This is primarily driven by 5 and under being unintentionally poisoned. And it's a near 6-fold increase since 2016 of children under 5 getting access to cannabis products and ingesting, and then poison control receiving calls. So just awareness as you message to families and about their use of cannabis and how these items might be accidentally accessed. Next slide. And I'll just wrap up on a reminder around Kratom, which I mentioned back in, oh yeah, so these are just some data highlights. You can go ahead and advance. I'd mentioned Kratom at the last call, and just you can go ahead and advance. Kratom is a leaf. There's an extract. 7-OH is a part of that. These products have been cropping up in a lot of gas stations and tobacco retailers, and so CDPH is continuing to collaborate with various state departments to help educate that technically these items are illegal to sell or manufacture for consumption. They're not technically illegal or sold to consume, like to own it myself, but to be a retailer selling it, it's actually not legal. And so we've been putting out a lot of content, a KHAN also probably coming out the end of this week to help alert clinicians about the rising use of Kratom and that there is a risk for addiction and overdose. And we have had deaths reported in California related to Kratom and 7-OH consumption. I think that's it for me. I'm just going to turn it back to Kim to take any questions or discuss any of the content we all collectively shared.
Thanks so much. Rita, as always, too, it's super great to have you on this call. Hopefully we'll be rejoined by Dr. Menorahs now for some questions. But I would just like to comment on my experience during this call in this year of 2026, when many of us are sitting in the face of news and communications that are full of anxiety producing and somewhat depressing information, to see the way that you are all contributing to, as Dr. Menorahs said, facing a very challenging situation and meeting it with an innovative mindset. It's just giving me a lot of happiness and satisfaction too. So I love to see Dr. Pond smile and really great. I'd like start with you, Susan, and can you help out those of us who are not familiar with this product or this project that you're working on? Can you make it a little more concrete? Can you, for example, give us an example of a technology or project that you might fund and how it might impact our patients or our work, the type of products you're thinking about being funding and how that's going to be public health focused?
Yeah, well, why don't I actually let Dr. Pond, she's been giving some deep thought about where there's opportunities for technological innovation for some of the challenges that she's been seeing for, some period of time, and now with the limitations in certainty and resources. So Erica, I don't know if you want to share some of the areas that that are at the forefront of where we're going to be placing our investments.
Sure. Yeah, I think some of our kind of what we're thinking about as low-hanging fruit is and that intersects with all of you as our frontline providers is you all are trying to report things to us, whether it's and actually one thing I was thinking about when hearing about Amanita poisoning and kratom. So those are not reportable diseases. So we're getting data from the Poison Control Center, but that's really different than reportable diseases. And when we receive reportable diseases, we're still using a lot of, as many of you know, sometimes very kind of old school ways of getting that information and then following up and investigating. So we really want to leverage technology and do a better job getting electronic case reporting from all of you. I think lab reporting has finally been largely automated, and we need to get to that place with cases too. And then also being able to follow up. I mentioned a TB case just now, or TB screening, and then once there's follow-up and management, public health nurses spend a lot of time going back and forth with the healthcare providers trying to get the data and information. And we really want to be able to improve these data integration systems and use kind of technology and tools to really better filter that information and get it more quickly. A big case scenario we've been thinking about as an example is, if we have another hepatitis A kind of food source and that gets really widely disseminated and we need to kind of alert and find that pattern quickly, if we can have more automated and smooth reporting of that to local health departments who can then follow up more quickly, see that pattern more quickly, help figure out what the source is, work with other partners to get that recalled, and also, really importantly, get post-exposure prophylaxis to people who are exposed. Those are kinds of some examples of, we're close on a lot of these kind of electronic case reporting, but we really need some acceleration of improving that so that you all don't have to be making phone calls, faxing or sending us a PDF that then someone has to manually look at, enter into a different data system. So that's like a key example we really want to improve upon.
Yeah, that's a great one. I definitely remember those days of filling in those forms, and that will be great. Speaking of case reporting, people are curious about an infectious disease that's spreading in other parts of the country, which is measles. Can you comment on that? One, measles in California, what's happening here, and two, with sort of changes in the CDC's infrastructure and ability to report these kinds of things. Are you finding it more difficult to hear from all the states and see what's happening nationally than you did before?
Sure. I don't have the most recent number for California at the tip of my fingers, but we did have a recent case in Northern California. I think I do want to credit vaccines and strong vaccine policies and high vaccination rates in California that I think has really helped us avoid some of these really large outbreaks that are happening across the country. And certainly we're hearing more in some of our adjacent states, which is concerning. As far as our being able to hear from partner states, I think we're improving these networks that I was alluding to around collaboration, but we already have, a Council of State and Territorial Epidemiologists, we have an Association of State and Territorial Health Officials, so there's a lot of cross-state sharing, and the CDC subject matter experts are still there and helping states and helping work. I think, a lot of the communications that has been more public-facing, I think has been less, but we are able to continue to partner with, again, career scientists who are still there doing amazing work and trying to continue their work. And so there is a lot of that collaboration that's still happening with various disease investigations. I think there is less sort of public-facing information that's coming out about those, but cross-state collaboration still continues very well, both with, I think, actual CDC coordination sometimes, or also with our other organizations that already are multi-state.
Great, that's really helpful. One of our participants was asking about, well, we've heard a lot about vaccine changes, and can you all hear me?
Yep.
All right, sorry. That we're wondering, what other changes do you expect or are already happening at the federal level that will impact our ability to do the public health work? And one example is the EIS program still happening and robust? And how is that impacting our ability to do outbreak investigations?
Yeah, thankfully my current understanding is that the EIS officer program is currently still resourced. I think a big upcoming new update will happen if and when the next sort of HHS budget passes with the discretionary funding. That is where I will back up and say, 80% of the dollars, I think this is right, Susan can correct me if I think it's something like 80% of the dollars from the CDC go out to state and local health departments. And then on the flip side here in California, it's about 45% of our budget is federal. And it's mostly from that discretionary budget that hasn't sort of passed yet. But there were a lot of threats, but there were so many different threats, it's been hard for us to know what's coming next. And then for us in California, with our 61 local health jurisdictions, it's roughly about 2/3 of our funding total goes to our state and local. So there's a lot of sort of downstream impacts once we do see what happens to that federal budget. And that's where we're kind of anxiously awaiting to see what happens with that. And again, there were very different amounts in everything from what the presidential budget was versus the House and the Senate. And I think they're, I'm hearing that they are close to some sort of negotiation, but I haven't heard like what is actually on the chopping block. So we're going to know a lot more, and we're certainly anxiously waiting to hear how that's pulled out. And I don't know, Dr. Menards, if you have anything else to add to that, but.
No, I think that's exactly right. And I think it's going to be a clear indication once that federal budget comes out, and then being able, and Dr. Pon's already doing this, anticipatory planning to be able to understand how those resources are potentially having downstream impact. And I actually, just getting back to the innovation side, is that's where, being it once there's greater clarity on how that funding is going to go, being able then to back into, well, what can we do to help offset those costs and continue to maintain the capability through an innovation engine that is then able to develop new or extend existing technologies to meet the gaps that are being revealed with that funding loss.
Yeah, great. Dr. Menards, as you're talking, you have worked across many agencies, the HHS, DHS, White House, ARPA-H, et cetera, and industry. How would you say that multidisciplinary experience shapes your approach as you look at public health in California and what we need?
Yeah, I mean, I've been so privileged to be able to serve in so many different roles. And so I've seen every single side of, this problem space. And I think what that allows me to do is to be able to listen to the concerns that Dr. Pon and her team are sharing in terms of capacity that is being eroded with these changing, factors, funding changes, but also the emergence and reemergence of new pressures, new threats within the public health space, and then be able to consider where might we find the solutions. Some are going to be in the big tech sector that is developing applications for other purposes. Some may be in an academic institution where they have been working on discovery that could be applied and scaled in a way that they hadn't anticipated. And I think it's just being able to harness just the insights from working across all of those different areas to be able to apply them now specifically in the problem sets for CDPH. And I just, I feel so fortunate that Dr. Pon and the governor's office had the foresight to be able to say, well, we're not just going to stand on the sidelines as this all happens. We're going to jump in and we're going to continue to push to be able to meet the moment with new strategies and new technologies. And it's just, I think it's just such a great opportunity. And I just want to thank Dr. Pon and her leadership to be able to say, we're not going to, we aren't just going to lose capabilities. We're not going to let down, the California public. We're actually going to continue to embrace technologies and continue to deliver for them.
Yeah, we are very grateful, and we're very lucky to have all of you on this call with us. We only have a few more minutes left, and I wonder if we could just do a quick round from each of you. Erica knows I always ask the hardest questions at the last minute. Maybe a quick thing on what you're most concerned about for 2026 and what you're most hopeful about for 2026.
I mean, I think I've already said them, but I'll just quickly and then allow it time for others. I think I'm most concerned about this budget actually that's about to come and what that's gonna, what the impact of that's gonna be. I guess that is top of mind just since we just talked about it. And then what I'm most excited about is Phoenix and working with Dr. Collar-Menares and really working to see what we can do in California. I'm incredibly grateful for the opportunity here to try to leverage the amazing community that's also been stepping up to really ask how can we help, what can we do, and hoping that will help some of our other partners in public health and science across the country as well.
Yeah, I was, what I'm most concerned about is the undermining of science and fact and truth and evidence and how that impacts both public health, but also clinical practice. That I think a lot of confusion has been sowed in the last year or so, that the public can't even tell what the truth is and what actions to take to safeguard their health and to safeguard their families. And I think it's similar to what Eric is saying, is like that's also what I'm hopeful for. Like I do see California and our partners standing up in a really strong and united way to try to give that sense of grounding and truth around science and fact. And so it feels good to just not stand, sort of by the sidelines and watch this happen, and just really appreciate the collaborative efforts and the partnership of like the clinicians here who are showing up. Like you are part of our network. You are part of the trusted voice that your patients listen to. So the more we can stay connected around what the messages are, what the analyses are of what's coming out, the more we can be consistent with our patients in the messaging, and so that truth can prevail.
And I'll just chime in. I agree with everything that Erica and Rita said. I think those are so critically important, and I share their same concerns. And what makes me optimistic is there is so much goodwill out there to help to solve these problems, not just observe these problems. And I'm optimistic with the Phoenix Initiative. I'm hopeful that we can get these investments from these non-traditional sources to be able to offset those funding, the funding that is being lost in the federal from the federal sector, and being able to demonstrate that when those funds come in, we actually use them to solve hard problems. And I think 2026 is going to be just transformational in how we do, the work here in California with CDPH, and just really excited to have all these new partners that are coming to work with us. And I'm an optimist by nature, but I'm so optimistic about how quickly we're already moving forward on all of this innovation.
Amazing. Well, I can see on my end as a frozen screen, so I hope you've been able to see and hear me well. Apologies if not, but I want to thank you all for being here as speakers, and particularly to our participants. Please do share this. We have the link is going to be available so anyone can watch this afterwards, this important information. We'll be coming back to you with more from the same team. And just to mention that we'll be hosting another accredited webinar on January 29th. This important webinar is entitled Words Matter, Removing Biased and Stigmatizing Language from Clinical Communications. And you can go to CMA's event page to register now. And again, a reminder that you need to fill out the survey to attest to your attendance if you do want CME, and you'll get your certificate. Thanks everyone, and have a wonderful afternoon.
Thank you.